Today, we're going to be talking about cognitive behavior therapy for psychosis with one of America's leading thinkers on this. I'm going to ask her if mind the gap, which is a British term when you're hopping off the tube, is in fact because this was developed in England. And we can ask that question a little later. Dr. Sarah Kopelovich is a professor of cognitive behavior therapy for psychosis. She's an associate professor at the University of Washington in Seattle. She's really a national leader in developing this model and making it available to people. She will also be appearing on our convention. Virtual convention this year is June 11th and 12th, and you can get access to some of the best thinkers in research, peer leadership, other approaches that you may want to connect to. It's all virtual this year, and I encourage you to do it. The registration fee is minimal. Let's go to the next slide, please. We have a fabulous helpline, and I just want to recommend it to people who may be interested or may be lost, trying to find a way to navigate our complex and underfunded and chaotic mental health system. NAMI's helpline is nationally accredited and has been staffed by over 350 volunteers who have a lived experience. They know a little bit about what you've been through. We're very proud of our helpline, and we encourage you to use it. We're so proud of it, we encourage people to consider volunteering for it. And you'll receive fabulous training. And 4 hours a week is, I think, what the basic expectation is, and you will be supporting people who are trying to find their way. This is not the National Suicide Prevention Lifeline. That's 988. Next slide, please. So some questions came in advance. I love your questions. I want to thank you for your engagement. Some of them weren't on this topic. So I want to commend to you our about 70 webinars with America's leading thinkers. And we can talk about any number of topics. They live on this website, nami.org/asktheexpert. So if you're interested in, I saw there was a question on antidepressants. We had the leading thinker in America's antidepressant discovery do a webinar, Dr. Maurizio Fava of Mass General Hospital. Some people are interested in other aspects of care. These things are recurrent, evergreen themes, and we really try to keep an up-to-date library. So I just want to commend that to you. So Sarah Kopelovich, friend of the family, she's presented at NAMI conventions in person. She's presenting virtually on the June 11th and 12th. She's really been a national force for good for advancing the idea of psychotherapy, a specific kind of psychotherapy for people living with a serious mental illness. So Dr. Kopelovich, I want to thank you for taking time out of your busy day at the University of Washington and for helping to educate people on this critical topic. Thank you. After her talk, I encourage you to send in your questions. We'll have a Q&A with Dr. Kopelovich right after her talk. Thank you.
Thank you for that incredible introduction. And in spite of the fact that it is sunny outside, and so most Seattleites are out on their kayaks, there really is no place I'd rather be than here talking on this subject. Obviously, I'm quite passionate about advancing psychological care for individuals with serious mental illness. I think I have a fairly unique perspective on this topic. I have sort of multiple vantage points on this issue. As a researcher, I look at the existing evidence base and its gaps. As a clinician, I am seeing every single week the toll that our current model of care has on our families who are navigating psychosis. And as a partner to organizations, states, and federal mental health policymakers, I really had an appreciation for how our healthcare policies are impacting everyday care. Before we zoom out, because that's a lot of it's a multi-positional perspective there. So before we zoom out on that, I just want to focus on an individual that I worked with. And his name is Jordan. Jordan is not his real name. This is not his real image. But this was an individual who I began working with When we met, he was 34 years old. He was living with his parents. Jordan has a really dry sense of humor, sometimes a little too dry for the Pacific Northwest. He has a deep appreciation of Philly cheesesteaks, and he creates his own manga comics. When Jordan was in art school, he began to hear voices. And they started off as mumbles that were confusing, and he didn't really know what to make of them. They progressed into these highly critical and narrating voices. And he really struggled to kind of understand what was going on. He took a leave of absence from school. He started to have this progression of not just of symptoms, but of what meaning he was making of these symptoms, of these experiences. So initially he was really fearful because he thought, well, what if these voices never go away? What if I'm stuck with these for the rest of my life? And then he started to try to understand where these voices might be coming from. And he didn't really have any models for understanding the experience of voice hearing. So he began to think, well, maybe these voices are being inserted into my head by the government. And as upsetting as that explanation was, having an explanation provided some relief. And so then that sort of spiraled into, well, maybe the government is monitoring me. And then eventually CIA operatives are following me and tracking my thoughts. Now, by this point, Jordan had broken off connections with friends and family. He was rarely leaving his room, and he had adopted these ritualistic safety behaviors, things like boarding up the windows, putting tinfoil around his door. He wouldn't let his parents get anywhere within 30 feet of his room with any electronic devices. And when his parents reassured him that these concerns were not accurate, that he really trying to reassure him, he started to think that he couldn't even trust them. They eventually were able to convince him to meet with a psychiatrist who diagnosed him with schizophrenia and prescribed medication. But it wasn't enough. He still couldn't leave the house. He was mistrustful, and he wasn't able to reconnect with the things that made him feel like himself. And even more so, he was starting to respond to the voices at all hours of the night, yelling at them. His psychiatrist mentioned CBT for psychosis, cognitive behavioral therapy for psychosis. There was just one problem. No one near him offered it. It's probably a pretty common experience. Many of you may have had that experience yourself, knowing about this intervention and not knowing where to access it. I'll speak to that during the Q&A, but first let's talk about what CBT is. So cognitive behavioral therapy is really become one of the most recognized psychotherapies. It's also the most well-researched psychotherapy. It is a time-limited, solutions-focused, structured form of talk therapy, where a typical course can be anywhere from a single session to around 24 sessions, depending on the chief complaint. And it's focused on these three most fundamental elements of the human experience. Our ability to construct meaning using language, and that could be in the form of thoughts, assumptions, interpretations, beliefs, memories. Even some people are more likely to think in images than with language. All of that will go under that thought category at the top of the triangle. Next is our emotional experience, which consists both of our feelings and the physical experience of those emotions. And then third is our behaviors. And each of these elements of the human experience are interconnected. Each impacts the other. And so a CBT therapist has to be really skilled in pattern recognition. We're looking for behavioral patterns and patterns in the ways that our clients think that are perpetuating their distress or perpetuating their disability. We use different techniques to draw our clients' attention to those patterns, and then we get their buy-in to try new strategies that in many cases can treat the symptoms to the point of remission. The elegance of CBT is in its simplicity. Once we understand the interconnectedness of these core elements, we recognize that we have the power to change any of these elements simply by altering one of the others. We can go one step further here, and we often will go this extra step when we're doing what we call formulation-based CBT, which is also sometimes called high-intensity CBT. And here we want to try to help build insights into where these patterns came from. And when we dig a little deeper in that pattern recognition that we're doing, what we notice usually is that about 90% of our thoughts that we have on a day-to-day basis are not novel. These are recycled thoughts that just keep popping up and popping up. And many of us are playing a game of whack-a-mole with those thoughts, right? Where we're trying to beat them down or ignore them, or we just feel beaten down by them. And when we start to actually pay attention to that pattern of thinking, what we can identify are these buckets of thoughts, these categories of thoughts. And those categories of thoughts are called core beliefs. What we are typically focused on in CBT, because we have a medical necessity to treat, right? So we're treating a particular form of distress or disability. We tend to see these core beliefs, which are operating under the surface, deeply held, and really priming us for those automatic distressing thoughts. They fall into these categories typically of, I'm not lovable, the world is unsafe. And when we can identify those themes that emerge, we can be much more effective. We no longer have to play that whack-a-mole because I know that thought. It's familiar to me. And I even know where that thought came from. And just because I thought it doesn't make it true. So there's so much empowerment inherent in this treatment. And we do not need to pathologize any of these elements in order to do really good work with our clients. And I just want to give an example. This is an example that I will often use when I'm training clinicians in CBT for psychosis to really underscore the universality of the kinds of mental shortcuts that our brains make that align with these core beliefs and how those can sometimes get us into trouble. So let's take a look at this quick commercial by AmeriQuest. And Hagen, let me know.
Hey, you got to get down. Come on.
AmeriQuest Mortgage, proud.
All right. I promise I'm not shilling for AmeriQuest, but they have fabulous commercials that really actually nicely illustrate one of the most common reasoning biases that we tend to see in individuals who experience psychotic symptoms or psychotic disorders, and that is this tendency to jump to conclusions, right? I'm going to make this mental shortcut to figure out what's going on, get locked in to that explanation, and then not explore alternative explanations. And so we don't have to get into this tug of war of whether the girlfriend's likely interpretation of what was happening here, being that her boyfriend or somebody had, was in her home and hurting her cat. We can really help. We can understand where that perspective might have come from. We can start to piece together how she reached that conclusion, and we can start to open up her mind to what she might be missing and some other possible interpretations, with kind of sidestepping this debate of, what is the truth here? What is the objective truth here? And that's really critical to doing CBT for psychosis, where we have to understand that psychosis is really seen as this transient or temporary break from a shared reality and into a retreat into an unshared personal reality. We want to learn about that reality. We want to ask curious questions to understand that reality and understand how it may have formed. So in formulation-based CBTP, we're doing a lot of work to try to understand what was going on at the time that some of these beliefs first started to get formed, right? What was going on for Jordan when it first occurred to him that he might be hearing voices because of the government. And we are not as concerned with objective truth. We're much more concerned with thoughts and behaviors that are balanced, helpful, flexible. I have to say, the best predictors of psychological health are how flexible your thinking is and your tolerance for uncertainty, right? I don't experience agoraphobic anxiety because I can tolerate the uncertainty of not knowing if I go out today whether something bad is going to happen, right? We all have to be able to tolerate that uncertainty. And so we want to enhance that in CBT. We want to enhance feelings of safety. And I am far more concerned about my individuals who I'm working with being more insightful about where these ideas, where these perceptions might have come from, what role they're playing in their life, how they might be holding them back, the role that stress has in those experiences or symptoms, than I am about the insight concerning whether they agree with their mental health professional's diagnosis of them, right? Because the former is really going to help them build a life worth living and live well in the context of having symptoms or distressing experiences. And one of the things that we have to do in CBT, and by the way, families are doing this every day as well, is we have to ride this collaborative fence where we don't get pulled into confrontation, which is really ineffective, whether we're talking about delusional belief systems, magical thinking, religious ideas, political beliefs. And so we're not going to change anybody's mind through confrontation. Similarly, we also don't want to be in the territory of collusion where we're saying, yes, you're right, this is totally happening. You know, my God, what do we need to do to keep you safe? Instead, what we really want to do is find the synthesis there. And that is to be able to empathize with the distress and say, you know, we may have different ideas about what's leading, what's contributing, where the voices came from, but we can definitely get on the same page about the fact that these voices are having a big impact on your life. And I think we could do a lot of good work together, regardless of whether we ever know for sure where the voices are coming from. And that process of writing the collaborative fence is really critical to one of the core tenets of CBT, which is this idea of collaborative empiricism. We're going to come together as equals, as two curious co-investigators. We can hold our beliefs, our conclusions, our assumptions with an open hand. We can start to explore these things together. And really, when we're using collaborative empiricism well, it sounds a little bit like Columbo, if you remember that show, this is a really outdated reference now. But our goal here is not to jump to conclusions. It's certainly not to tell people that their beliefs are wrong or what to think. It's really to help them become more critical thinkers of their own inner dialogue by asking curious questions. And I have to say that the strengths of that kind of approach, they benefit everyone. I think they particularly benefit communities of color, where we can focus more on resilience and meaning and coping, which will align with cultural values, right? Where we are starting to make sense of distressing experiences, like hearing voices, as understandable reactions to stressful or even traumatic experiences, rather than as signs of personal failure or as solely a biological disease. And that could be really helpful to reduce stigma in communities where mental illness may be highly stigmatizing. I would say this kind of approach also really fosters agency and empowerment. It's probably what I love the most about CBT. And particularly in communities of color or communities historically harmed by discriminatory or coercive practices, in mental health or in the medical system. I think that this is really becomes an invitation to our clients to partner with mental health in a new way. We are really focused on understanding different kinds of explanations for our clients' experiences. And that includes cultural explanations, which means that we really need to pause before we pathologize all behaviors and experiences. And we really need to make sure that we are seeking cultural expertise as needed. And then the CBTP can be adapted and has been adapted to incorporate spiritual and cultural beliefs as well. I do want to note CBT for psychosis, which is what I'm talking the most about today, is not the only psychological treatment that's indicated for the treatment of psychosis. You can see these are all of the recommended psychological interventions that are included in the American Psychiatric Association's schizophrenia treatment guidelines. The ones on the left-hand column where you see an asterisk by, these are interventions that play really nicely with CBT for psychosis, either because these interventions are integrated into CBTP or can be integrated, or because you can do these concurrently or sequentially. CBT, as I mentioned, it has the largest evidence base. So I do want to talk about that evidence base specifically for CBT for psychosis. We have more than 50 randomized clinical trials. We have 20 meta-analyses and 7 systematic reviews and counting. These numbers always grow with every presentation that I give. This is a substantial body of evidence now. When we look on the whole, this is where I have to summarize 30 years of evidence in 30 seconds, which is a fun game to play at conferences. We do find that CBT for psychosis, when compared either to what we call a non-active comparator, meaning like a waitlist control, or an active comparator, like another form of therapy, we see statistically significant and clinically significant effects on hallucinations, delusions. And I should note that our effect sizes for hallucinations and delusions are on par with most antipsychotic medications, with the exception of clozaril. So we're typically seeing moderate effect sizes for those positive symptoms. We see smaller but still significant effects on negative symptoms. We see improved functioning across different kinds of domains like work or quality of life. We see a reduction in the duration of hospitalizations, improvements in mood and anxiety. And then this is a really significant finding that when we look at follow-up, at studies that include a follow-up period, we tend to see that CBT for psychosis will maintain gains post-treatment. And that's unlike a lot of our other interventions. Some of our interventions, they're good for as long as you're doing it, and then you'll see those effects kind of wear off. CBTP does seem to be indicated across the illness spectrum. So there's evidence that it can minimize the risk of transitioning to a psychotic episode among those who are at clinical high risk for psychosis. What we're focusing on is going to look a little bit different depending on the stage of illness. So for clinical high risk, we're focused on addressing attenuated symptoms and addressing comorbidities, right? So addressing the anxiety that we almost always see in this clinical high risk population, mood symptoms, poor sleep, those are critical targets in CBTP for clinical high risk. And then first episode psychosis, we really want to help them with that recovery. We know that many folks will go on, to achieve full recovery without having a subsequent episode. For those who do, we're really trying to prevent relapse. And ideally, we're really trying to get at those underlying core beliefs so that, again, our clients and we are not playing that game of whack-a-mole. There have been a number of studies and even meta-analyses now looking at CBTP administered either in the absence of medications or for individuals with medication-resistant psychotic symptoms. A lot of this work has been done in the United Kingdom and in Germany. A study I really want to call attention to was a study by Toni Morrison and colleagues in 2018. This included I think somewhere around 500 individuals with clozapine-resistant psychosis. Half were randomized to 26 sessions of CBT, half to treatment as usual. They found greater improvements in the CBT condition, but the effect washed out at follow-up. And so the authors concluded, and I agree with this, that 26 sessions is probably an inadequate dose of the therapy for that population. But across these studies, we really see there's general consensus that CBTP can be used and is considered effective for individuals, even with medication-resistant psychosis or those who choose not to take medications. So let's get back to Jordan. Obviously, Jordan's story is not unique. Across the United States, 100,000 people are diagnosed with a psychotic disorder each year, which is the equivalent of about 274 people a day. It will take the average American between 1 to 2 years to connect with treatment, and that's down from about a decade ago. And that is if they're connecting at all. So about 1/3 of Americans with serious mental illness will never receive care. And of those who do, fewer than 1% will receive even a single session of CBT for psychosis. So what this means is that many families, many American families, are never told that CBT for psychosis is an option, like Jordan was, and fewer still can access it. And that is in spite of the fact that there is now clear guidance from some of the most respected governmental and non-governmental mental health organizations. So in 2021, the Substance Abuse and Mental Health Services Administration issued a position statement that CBT for psychosis should be part of our mental health system. At a minimum, it should be delivered in mental health, and then CBTP informed care at a minimum should be available in primary care, correctional, forensic, and educational settings. And around the same time, the American Psychiatric Association reaffirmed that therapy and medication go hand in hand. And actually, if you read the family version of these treatment guidelines, they actually say that medications are a complement to psychosocial treatments, and psychosocial treatments are an equally important part of care. So let's talk about access. Why can't Jordan access CBTP? It's very clear now that the implementation of this intervention is more than 30 years behind the science. I spend a lot of my time thinking about this problem and trying to identify the factors that are stalling CBTP implementation and then redress those factors. There's a lot of different factors, some of which are unique to the US and some of which are universal across high, middle, and low income countries. In the US, roughly half of our US counties, which amounts to about 170 million Americans, are living in a mental health practitioner shortage area. What that means is that they are without a licensed psychiatrist, psychologist, or social worker. So who are people going to get CBTP from if they're in one of those shortage areas? And of course, those shortages are particularly prominent in rural areas and in economically stressed cities. We also see poor access to training, and this is obviously something that I spend a lot of my time trying to remedy. We know that because of resource scarcity in our mental health system, our system is really oriented towards crisis and also biological interventions, which just require less time from healthcare professionals in an ongoing way. We can get people to the point where they're doing once every 3 months med management sessions, whereas psychological care, it really is an investment of time and resources. to provide that. We also have to identify referral pathways for getting people to the psychological care that they need. And we need schedules for our practitioners to be set up to accommodate 45, 50-minute psychotherapy sessions. And then we have concerns around payment models. So our payment models currently create disincentives for providing evidence-based psychological care. It requires more time and more effort for the practitioners, and yet they are paid the same amount, they're reimbursed the same amount as if they were providing a befriending session, a supportive session, or literally if they were to fall asleep in the room with their client. If our payment model is based on time and not on outcomes or evidence-based interventions provided, then it creates a real disincentive for evidence-based psychological care. I'm going to focus on 3 of those 4 issues because I really have no pull in the payment models. So I just want to focus on 2 examples of areas of ongoing research that are intended to expedite the pipeline of science to practice in this area so that we can start to change these realities. So first of all, we need to be thinking about how do we integrate CBTP into our systems of care. And rather than waiting for this ideal scenario to hit, we just need to meet our care settings where they're at. So we know we have tons of research now that affirms that a range of healthcare professionals, paraprofessionals, and non-professionals can learn CBT concepts and skills. And we are seeing CBT stepped care successfully implemented in England's National Health Service. I have spent time with NHS central leadership trying to learn from them and see what is applicable to our healthcare setting. And in 2017, I adapted their stepped care model for the US context. And my goal here was to make CBT a universal language. I want all of these providers and allied providers and families to all be speaking the same language. And what's really nice about using CBT is that it has different dialects, by which I mean there's different versions of CBT that we can teach people based on their role, based on their scope, and based on their pre-existing knowledge. So we can train peer support and employ vocational specialists and psychiatrists, ARMPs, to integrate high-yield cognitive behavioral techniques into their work with clients. We can have our case managers who are doing low-intensity CBT or CBT-informed case management. We can have, I hope, psychotherapists in this multidisciplinary treatment team who are able to do formulation-based CBTP and hopefully even incorporate digital mental health interventions so that individuals have access to skills coaching in real time, whether that's at 2 a.m. in their bedroom or 2 p.m. on the bus. And then finally, we need to be training family members in how to talk and think in that CBT language as well. And so along with my colleague, Kate Hardy at Stanford, and one of our CBTP treatment developers, Doug Turkington in the UK, we developed a CBT-informed intervention for families and caregivers. And I just want you to hear a little bit about that intervention in their own words.
Because it's mystifying when you find out that your child has a serious mental illness and we really don't know what to do. And that's where the CBTP gives you, baby steps of how to work through this and see things happening for yourself.
We know our loved ones' situation better than anyone else. And we're in a position to have enough confidence in what we've learned in order to be able to apply some of these things and just give them a try.
That's human nature. That's not a psychosis phenomenon. That's what we all do When somebody discounts or refutes our experience or our political views or our religious beliefs, we dig our heels in. And actually, Amy, what was so important in your response, it was really quick, so people might have missed it, but she actually said, I think you might have paid him to do experiments on me. So it's very easy to transition if we're denying our loved one's reality, for them to think, well, maybe they're in on it, right? Maybe that's why nobody's telling me the truth.
It gives you a stronger stance to take on various challenges. And you're learning from the instructors in the class, you're learning from the other participants in the class.
Mm-hmm.
And so, you know, we feel we're pretty well trained in dealing with individuals that may have behavioral health issues.
Sobbing on the phone with my husband because it was the first time anybody in this journey has said there's a chance of recovery. You know, this is our life.
To see this group from the UW actually devoting and intending to improve the lives of the individuals and the families with this illness, and then to see a group of other families who are equally appreciative of the academic research, the evidence-based research, and the in-person compassion is like getting one great big group hug to know someone cares about our loved ones in a concrete way that could possibly make a difference in their lives. It's this one big group hug.
I have the website up there on my closing slide, but I just want to kind of summarize what this model looks like. This was a model that I articulated in a paper published in 2018, and then I published data on the first 4 agencies where we implemented CBTP stepped care. And so really our goal here is that we want everybody to learn about foundational principles and foundational skills in CBT for psychosis. We want some folks at the agency who are not therapists, or maybe they have some therapy background, to learn some of these low intensity CBTP interventions. We can have both therapists and allied professionals work together to administer CBTP in groups, and then we would be training the smaller number of licensed master's level or PhD level folks in high intensity CBTP. And we looked again at 4 agencies in Washington State. We compared those who had gotten trained in CBTP stepped care to some historical data that we'd had on folks that had only been trained in that high intensity formulation based CBTP. When we looked at just acceptability, feasibility, and appropriateness, we found very, very high rates. Nearly 9 out of 10 folks agreed that it was acceptable, that it was appropriate. We always tend to see a little bit lower the feasibility because there's some systemic and structural barriers to implementing the intervention. In terms of our reach, and this is really the holy grail from my perspective of implementation outcomes, right? Are we getting this intervention out in the way that we want to? When we used the stepped care model, we were able to reach 3 times the number of providers in this training, and then they were able to increase 3 times the number of clients with the intervention. So that's exponential increase. That's not additive, right? And then when we look at the quality of the work that those clinicians were doing, by the 12-month mark, we were able to get 80% of the folks that we trained to competence in CBTP. At that 12-month mark, all 4 of the agencies had sustained all 3 levels of care. That was low intensity group and high intensity. And 81% of the folks that we had trained were still delivering CBTP. So this is really exciting and really promising. We have a lot of progress here that stepped care could offer in terms of being able to get this intervention out to more folks. but we still have a scalability problem. Psychotherapy is very difficult to scale up. So one recent study, it's actually not that recent anymore, it's probably a decade ago, estimated a cost of around $20,000 per beneficiary, meaning per individual receiving the therapy, that was associated with the gold standard model of training. And that gold standard model, in addition to being pricey, is also very difficult to access. And when we think about how adults learn any new skill, even complex, or maybe especially complex skills like psychotherapy, it really rests on two critical ingredients: repetition and feedback. And preferably that feedback is going to occur as close in time to the behavior as possible. So think about that teacher at the elbow model that we see in surgical residencies and fellowships. And we need that kind of training. We need those training opportunities, not just to improve clinical outcomes, but training is a workforce retention strategy. And we have a huge workforce retention problem in mental health. Employees stay longer at jobs when they feel effective. So I was thinking, how do we address all of these concerns? We've got the high cost and poor access to psychotherapy skills training. We need to provide multiple opportunities for repeated practice and proximal feedback. And we need help to grow both the competence and also the confidence of our workforce. And one way to do that is to automate training and feedback with responsibly developed artificial intelligence. This is not unsupervised open models like ChatGPT. We're talking about highly specialized, rigorously tested tools developed by subject matter experts. So is actually just as the pandemic was hitting, 2020, I was awarded a grant from the National Institute of Mental Health. It was a fast track study. It means we went through this pipeline in 4 years where we conducted user-centered interviews to understand what do clinicians in practice need and want out of an online training tool. We did these design sprints with our partner that was doing all of the CS and all of the back-end machine learning algorithms and the NLP. And then we developed and validated a fidelity tool to be able to assess learner responses and to train the machine learning algorithms on what we consider to be high fidelity quality responses. We then got a data set of about 5,000 responses to a set of 28 prompts. These are prompts from clients to set learners up to provide a response that could be judged then by the machine learning. And those responses were then used to train those algorithms and then to be able to validate that we were getting it right. And what we found actually was that the AI was able to be even more accurate, more reliable with my assessments than even other raters would be. We then conducted a single-arm 2-week field trial just to identify bugs and make last-minute tweaks to the clinical trial protocol. And then we conducted a randomized clinical trial with 100 providers and 300 clients. We are analyzing that data now. So I expect to have those results published within hopefully the next 6 months. I just want to give you a quick glimpse into what this would look like so that you kind of get a feel for what a learner might be exposed to. So you'll see our learner in the lower left-hand side as he's navigating through the training tool. Again, learners can kind of pick what they want to look at. And then each of the modules is set up in the same way. Our learners are going to watch a short form video where I'm providing the rationale for the skill. They're then going to learn. They're going to do some self-guided didactics with just a little bit of learning content that follows this video. And then they immediately put into practice what they learned.
That CBT can have lasting benefits for clients with psychosis and can reduce the risk of relapse and rehospitalization even after the treatment has ended. How does CBT accomplish this feat? By using the last stage of treatment to prepare our clients to stay the course. In other words, to pursue their wellness regardless of obstacles or setbacks. There are 3 things you'll want to explore when setting up a wellness plan with your client: triggers, early warning signs, and a relapse signature.
So the learners can watch this video to really motivate them and entice them to change their practice in this new way, to incorporate these skills and strategies. They're then going to guide themselves through the learning content. Anything that's underlined is a little Easter egg in there where if they're interested, they can learn a little bit more, go a little deeper in their learning. And then they get the opportunity to practice with their clients. They're going to read their instructions. They're going to select the client that they want to practice with. And then they're going to listen to what they have to say and record their response.
Just worry about everything just falling apart again. I was in and out of the hospital over a dozen times, and the last time was the worst. I lost years in that state hospital, and it was awful. It made me feel, it just made me feel like everything that the voices said about me were true. I feel better than I have in years. The voices are still there, but I feel more in control, and I don't have to listen to everything that they say. But what if I come undone again? I just don't want to lose control, and I don't want to lose everything that I've gained. And it's scary to think about that. And it makes me feel like maybe I should settle for less.
All right, so let's hear the learner's response.
Angel, I think that's an incredibly valid concern, especially given your journey, the journey that we've taken together so far with this. I think what's important to remember is, first, that progress is not linear, and 2, you've done some incredible work and incredible progress in these sessions we've had together. When those moments of uncertainty arise in the future, or if there's ever moments of doubt, remember what we've talked about and the skills that we've developed together, and know that I'm always here to help if you need it.
This is such a perfect example because it's really consistent with what we might hear from a junior clinician. Very supportive, very warm. Let's see how the AI rated it. So what you're looking at are 2 scores. One is interpersonal effectiveness, because that is the backbone of any good psychotherapy, right? We have to be able to demonstrate warmth, empathy, and positive regard for our clients. We definitely heard that in this practitioner's response. And so he scored in the moderate range for this. But what we see is he scored quite low in wellness planning. And that is because you did not hear any mention of a wellness plan, a relapse signature, triggers and early warning signs. And remember, when we coach our clients to be able to plan ahead and incorporate, sort of consolidate what we've done in CBT and incorporate that into their wellness plan, we're setting them up for that outcome that we talked about earlier of maintaining gains post-treatment. So this clinician can now try again, or he can also listen to an expert response. All right, so lots of really, I think, exciting developments in the implementation front. There's also a lot of exciting developments in CBTP treatment development that maybe we can get into during the Q&A. I think what I really want to emphasize for this community, that the NAMI community knows all too well, that when we build coalitions to exert pressure on decision makers, good things happen. And that's really what we've done in Washington State. We've had family members, people with lived experience, clinicians, researchers really come together, and that has enabled us to have dedicated funding from the state. So I just want to show you a little bit of what we've built in Washington.
Psychosis feels like you're losing your grip, like being in a crowded room. Having so many things coming at you, voices, images, you can't sleep. I was homeless for about 3 years. I just felt like I couldn't do anything right. Not knowing how to do stuff that I used to know how to do. Going shopping, walking down the street. I felt like everyone was talking about me everywhere I went. Even going to check the mail was scary.
Psychosis is when an individual retreats into their own perceptions, their own thoughts, their own understanding of what's happening.
Some people see things that other people can't see. Some people will have really worried thoughts or feel like people are coming after them specifically.
Cognitive behavioral therapy can help them to start to break out of their cocoon. Our work at the Spirit Center is really about how we can train and prepare the workforce to provide culturally informed, trauma-informed, and empirically supported care. Our mental health system is doing the best it can with the limited funds that it has, but we need to do better. How do we help? How do we solve this problem? Traditionally, our medications have been on the front line, but our medications are not enough. Psychotherapy helps people learn about themselves, about what helps and what makes symptoms worse.
They had mentioned to me 2 times about taking CBTp, and at first I thought, I don't want to take anything like that. I don't want to be in group. But this seems to be more tailor fit for me. My therapist made me feel understood. They just asked me things that no one has really asked me about my voices. I didn't even know that I wasn't being honest with myself about my voices. It was eye-opening, and I don't think I would have been able to do that without the therapy.
Cognitive behavioral therapy for psychosis, it's different in that really you can meet people where they're at, regardless of where they're at in terms of their recovery. It's just very flexible, and it's really person-centered.
CBT has increased my confidence to talk to people, to walk down the street. I got so comfortable, I went and checked the mail in my socks. So I just felt at home in my own body. It really takes therapy to another level.
The data suggests CBT is one of the most effective and efficient treatments that we have.
I feel like I'm more effective with my client, and I feel like I'm able to measure their progress and see their progress. It's given people confidence in their ability to manage their symptoms, to see somebody do a 180 and all of a sudden be baking again, be traveling. It's amazing.
To be able to facilitate that kind of change. That is remarkably powerful to a clinician.
I feel much better equipped as a therapist having been trained in CBTP. They don't teach you how to treat individuals with psychosis in grad school. It was excellent working with the UW Spirit Center. Their training's really in depth. There's so much support, right? You always have somebody to go to if you have a question or if you're confused about something.
The mission of the Washington State Healthcare Authority is to provide access to health care for folks in the state of Washington.
The state has partnered with us since 2015 to train the workforce in cognitive behavioral therapy for psychosis. When we train clinicians, we ask them the question, do you have a clear sense of how to work with people with psychosis? And only 17% agree with that statement. By the end of our training, 95% of our trainees say that they have a clear sense of how to work with people with psychosis.
It's important that the state continue to fund workforce development, and we also need to support individuals in trainings for these types of evidence-based person-centered care models like CBTP.
We need systemic investments to help change the course for the millions of Americans who have psychotic disorders.
When we invest in the workforce, we invest in the health of the state.
I believe that it should be easier for people to get treatment in Washington State. We live with hearing voices, and it's scary. And I just want them to know that they're not alone. If you don't want to live like that, you don't have to. CBT has increased my confidence 100-fold. It's helped me in my life just being.
Right. I know we are going to get into talking about where training can be accessed. So I just want to leave you with a few resources to prime you for that discussion. If you're a family member wanting to get trained in CBTP for families, you can go to our website, psychosisreach.org. If you're a practitioner or want to send this to practitioners, you can go either to the UW Spirit Center website or to the North America CBT for Psychosis Network website. And if you're curious to hear a little bit about what CBT is like from the perspective of both the therapist and the client, you can go to, I think this was episode 1 or 2 of the Medical Mind podcast, where Ken and I have a little discussion about it, and you also hear from an individual client. So I will just leave these up for a moment until Ken tells me to take them down and turn things over to you.
Oh, we can chat with them up for a bit.
Okay.
So thank you, Dr. Kopelovich. That was fantastic. A lot of questions, as won't surprise you when you have close to 700 people. So I'll do my best to condense them. I live in, pick state, New Jersey, Illinois, the On-Track program in upstate New York City. Where do I go to find somebody who's experienced this training? And I know this is a major challenge, but I'm very interested in attending to that question as best you know.
Yeah, absolutely. It's a really important question because it is the most frequently asked question. Great, I'm in. Where do I get it? So well, first you should know I'm working on a directory that will guide people to CBTP trained practitioners across the United States and Canada. That is my number one mission as the current president of the North America CBT for Psychosis Network. So that is in development. There is also, when I was growing up, I would like write letters to people, just like about things I was angry about. So when Quantum Leap was canceled, I wrote lots of letters to NBC about that. So I wrote letters to Psychology Today because they didn't list psychosis as one of the focal problems in their directory. And I have no idea whether that had any influence whatsoever, but what I can report is that psychosis is now listed. So you can go to the Psychology Today website, look at their directory, and select psychosis. In Washington, I know Washington does have a directory of CBTP trained agencies. We don't get down to the provider level. We do have a few folks on that list who are in private practice, but all of my work is really focused on training up publicly funded behavioral health care settings. So we've got all those agencies listed. I know California is working on their own directory of CBTP practitioners. So I think it's going to get easier in the coming years to be able to locate trained providers. But I absolutely 100% recognize that struggle.
Yeah, so this is a growth stock. It's a better idea. And you're working to develop a directory. So for now, if you live in New York or New Jersey or Chicago, you have to ask your local agency and advocate for both the state mental health block grant and that local agency.
Yes.
And your local NAMI.
Advocate.
Very few things get done in American mental health without NAMI to advance this from an advocacy perspective. When the directory is up and running down the road, and I know it's a big, messy task, where might a person find it?
Oh, so that's going to be on the North America CBT for Psychosis Network's website, which is just www.nacbtp.org. And you could go there now. I would say, folks, there's a lot of networking that kind of goes on we have a community of our families who we've trained through Psychosis Reach, who will oftentimes exchange resources. I know that happens in NAMI communities. So it really is now about kind of networking and trying to ask around. But the other thing I will say is if your loved one, or if you are within the first few years of the initial psychotic episode, it is far easier to access CBT than if you're outside of that window. And to a certain extent, it's also easier to access a CBT intervention if you're in that clinical high risk scenario, because SAMHSA has funded clinical high risk programs across the US. And you can find a directory of those teams, where those teams are across the United States, on the PEPNet website. PEPNet is PEPPNET.org. And that's really, they house the national directory for all of the first episode psychosis care teams. Most of those care teams will include psychotherapy. Most of that psychotherapy is either CBT or CBT light.
Just back up 1 second. One of the best ideas in American mental health is cognitive behavior therapy for psychosis. A different, best idea. These are like some of the really remarkable developments is coordinated specialty care. And that is a way to get a comprehensive psychosocial, supportive, family engaged work with people in the early stages of psychosis. And that's PEPNet. There's almost 400 programs of this across America. NAMI was super involved in advocating for this and getting it tucked into the block grants across the country. So if you're in your first 5 or 10 years of psychosis, and again, the admission criteria depend locally, that is a great program. And I suspect a lot of them are doing CBT for psychosis as part of that.
There's something else I just want to add here, because I think it's really important for folks to know. Plan A is you find somebody who is trained in CBT for psychosis, but there are contingency plans here. So if you don't have a provider locally who's trained in CBT for psychosis, here are some additional options. One is there's something called PsyPact. PsyPact is PSYPACT. And this is something that allows psychologists to be able to practice interjurisdictionally. So typically a psychologist, a psychiatrist, social worker can only practice in the state in which they're licensed. The PsyPact is going to extend reciprocity of their license to other states that have entered into that pact, into that agreement. And so it enables us to be able to treat clients who are living in different states. So you could look for a psychologist who's not in your state, but they are part of that PsyPact agreement if you are okay with telehealth. Another option is that you can look for other forms of therapy that can have a knock-on effect on psychotic symptoms. So there's a substantial body of literature that suggests that if we are treating sleep disturbance, which we very commonly see in individuals struggling with psychotic symptoms, if we are treating anxiety, if we are treating substance use, that we are going to have an impact on the psychotic symptoms, even if we're not able to treat those in a more direct manner. So if you have somebody who knows CBT for worry, fabulous, connect with them. And then I would also say kind of the option number 3 is, even if your loved one or you only have access to a therapeutic intervention like supportive psychotherapy or befriending psychotherapy, which doesn't have the active ingredients of CBT, you are still likely to see benefit. What we know is that you're not going to see benefit for as long. It's not going to be as, we're not going to see it as much of the impact on functioning, but you're going to see a lot more relief. You're going to see more connection with other people. And that can only be a good thing. So investigate plan A and then look at those other options.
You did answer indirectly a different question, which is, can CBT for psychosis be delivered virtually? It sounds like the answer is a clear yes.
Yes, it can. And in fact, I wrote a paper on this with Dr. Turkington that we published during the pandemic. And so I can send the citation to Nami, and maybe you can post that paper with the recording of this talk. But we talk about what kind of adaptations are indicated for tele-CBTP. There's been a lot of work done in this area by Tanya Lecomte, who's a clinician researcher up in Canada. You do need to make some adaptations, and I will say it's not right for everyone. One of the concerns that I have about doing CBT for psychosis via telehealth is that oftentimes when we're doing CBTP in the community or in clinic, our clients have to leave their home. And that's helpful. That's important, right? You don't actually have a recovery lifestyle if you're only ever at home. So it becomes an opportunity for them to have more socialization. It becomes actually an opportunity for their anxiety to get a little activated, which then better enables us to treat the anxiety. So I don't like to use telehealth for clients that are really in their homes a lot and, maybe even engaging in some agoraphobic avoidance. And then some clients have concerns or challenges with technology. And so there it can be less than an ideal
So
fit.
it can be effective in selected circumstances, but it's definitely not for everyone.
Yeah, and I think you just need to use some clinical judgment too around that.
Question was asked if a person has had traumatic experiences and is fearful as a result of that. So CBT asks a person to reflect upon their recurrent thoughts, and their thoughts may be high on the fear anxiety scale. Could you just talk a little bit about that? Because obviously some of this experience is rooted in reality for them based on their own experience. So how do you help with somebody sort that?
Absolutely. So first of all, trauma histories are very, very common. Oftentimes what we see is that when we look at the experience, that some experiences that folks have had early on in life, there are capital T traumas and lowercase t traumas, right? By which I mean we have some that will meet that threshold that the DSM has set for criterion A traumatic events, but we are almost always seeing some kind of level of trauma that is playing a role in what the individual is experiencing. So examples might be a rejection from, they were rejected by their spouse or boyfriend, girlfriend, or they experienced a history of racism and racial stress. And so we really do need to understand that those trauma histories that our clients are coming in with, because we oftentimes see themes from those traumas present within the psychotic symptoms, and it becomes really kind of entangled. I think the most important thing is that we're not in the business of arbitrating truth. We do not need to investigate. When I was just learning CBTP, I remember thinking like, what, could this have happened? And, is it possible that he really did write all of Elvis Presley's songs and, kind of take to Google? We don't need to do that level of investigation. We need to tap into the distress that person is experiencing. And many of the delusional systems or the unusual beliefs that our clients have had in their lives are so frightening. They are so scary. Any of us would feel hypervigilant, would avoid reminders of that experience, would have that trauma echo. And that's oftentimes how I'll explain things like voices or these intrusive thoughts to my clients, is that these are trauma echoes. And that's something that the human mind can do. So I think having that lens, that trauma-informed lens, is really important. If you ever find yourself with a clinician who's trying to judge or adjudicate the veracity of that experience, it's really not necessary and not productive.
Go Zen on that. So that's also a tip for family members who are working. Several questions were, how can I support my loved one? What's the best approach, right? So this idea that you're not trying to arbitrate truth, you're trying to help them attend to their emotional experience, which may be getting in the way. Do you have a book or resource for families to read or review, or do you have a favorite resource? Like if a family member couldn't find CBT for their family member, but they wanted to get started to understand some of these principles.
I have two that I recommend. One is an oldie but a goodie. I guess I had three, and they're all at least co-authored. I think they're all co-authored by Doug Turkington. I got a lot of my training from him, so it's probably not too surprising. He, along with David Kingdon, wrote what many clinicians still refer to, which is cognitive therapy for schizophrenia. It was last published in 2005. I still train to that book. And what's really nice, so it is written for clinicians, so that's the caveat. But the really nice thing about that book is that they give different clinical vignettes so that you can see how each stage of therapy or each strategy will look with clients who are presenting with a different constellation of symptoms or concerns. The second book I recommend is called Back to Life, Back to Normality, Volume 2. That was also co-authored by Dr. Turkington. That is for families and for people with lived experience. It leverages one of the core principles of CBT for psychosis, and that is normalizing, right? We can really understand that these experiences that we once said, that's pathological, that's different, that's not the common human experience, is just an extension of human experience. It's on the same spectrum, hallucinations on the spectrum of misperceptions or illusions, delusional beliefs on the spectrum of unusual ideas. So I really think that that's a fabulous text for families, and it's the one that we most often recommend in Psychosis Reach. And then the third book I recommend is pretty hot off the presses, and that was co-authored by Dr. Turkington and by Kate Hardy, and that is called Decoding Delusions. And again, that one is oriented toward clinicians primarily, but it's fabulous for really giving a nice understanding of where delusions and unshared beliefs come from and how to treat them, including how to work more effectively with families. And that was the chapter in the book that I wrote.
Well, fantastic, Dr. Kopelovich. I want to thank you for all your work. Thank you for donating your time to advance people's knowledge. Thank you for coming to our virtual convention next month and for everything you do. Hagen, let's advance the last several slides. So we have some other fabulous people coming up. Supported employment has been demonstrated to be the best way to help people with something that they frequently say they really care about, which is getting a job. And supported employment is a model to help people keep a job. Trauma is a topic that Dr. Kopelovich discussed. Dr. Bruce Perry wrote a best-selling book with Oprah Winfrey, and he'll be discussing trauma in July. Next slide, please. If you're interested in learning from people and learning from families, here's NAMI's series of books. Dr. Kate Hardy did write about cognitive behavior therapy for psychosis for the first book on the left. But it's a lot of interviews with real people who use their names, who are learning how to navigate their own mental health. And I also interviewed families in that book. Dr. Christine Crawford attended to the same process for parents with younger kids and also talked to teachers and other people in kids' lives. And all the royalties go to NAMI, so I promote it with no guilt. Next slide. Here's some of our sponsors for the Ask the Expert series. We provide these for free and are grateful for people who help us. Next slide, please. You are not alone. This is not a medical advice, psychological advice. This is simply a process of improving your educational game. If you're so moved to donate, we appreciate that. The link for that is below. Next slide, please. Thanks for joining. My name is Ken Duckworth. It's my good fortune to be the Chief Medical Officer of NAMI. You can reach me at ken@nami.org. It's so easy, even I can remember it. No one is allowed to work for a national NAMI named Ken. So if you're applying for a job, please use your middle name. Ask the Expert at NAMI.org is the way you ask for future topics. This is something I care about. Everybody loves NAMI. We love our researchers and our experts, lived experience or formal research. So we ask people and they say yes all the time. With that, I want to thank you all for attending today. I hope you can join NAMI's virtual convention, June 11th and 12th. We'll be having some all-stars discuss different topics. Thank you, Dr. Kopelovich, and thank you everyone for attending. Bye now.